This is a video of a surgical technique and vitrectomy combined with cataract surgery. I had some trouble in that, and IOL is not and placed in the right position, and possible resulting in IOL falling. So I managed to the fixation of IOL by manually, and then so to avoid the IOL falling to the bottom of the eye. And finally, I successfully to fix IOL haptics on the back. And this is uncommon surgical complications and combined phaco vitrectomy. And haptics and on the back just now.
So comments from the panel? So why did you have difficulty, Kazuaki?
Sorry?
Why did you have the difficulty?
Yes, I performed the core vitrectomy, and there is no the vitreous and the IOL almost in the falling of the bottom of the eyes. It is very difficult, and also the posterior and capture and membrane ruptures. There is no barriers and to fix and the IOL.
So the zonules were loose?
Yeah.
Any other comments? I just want to ask the panel what kind of an IOL they usually use in an aphakic patient. So if you do a postprandial lensectomy, Manish, what do you usually use as a lens implant?
No, I don't do it myself. I just let my cataract specialist, we plan it beforehand that in this patient what would be the best secondary, or sometimes they do a posterior iris fixated lens based on the pupil, and if it's post-traumatic and if pupil has an issue, then they take a decision on that.
David?
I almost never do a lensectomy. So I almost always will do a phaco, because then even if the lens drops, I can deal with that. But if I can get an intact anterior capsulorhexis, I prefer a sulcus IOL than dealing with an aphakic situation that I've created by doing a full lensectomy.
And if you have a subluxated IOL, what do you usually do?
I've tried everything, so Yamani techniques, etc. But I guess my only caveat with this, and I say this to our fellows all the time, all these kind of sophisticated IOL repositionings, we all have a chance to play around with those, but don't forget about putting in an AC IOL. I mean, I think all the modern literature now on ACOLs shows that they don't cause the problems that the previous ACOLs did decades ago, right? So it's easier, it's safer, it's simpler, it's quicker, etc.
Wai Chin?
I agree with David, and especially if it's an elderly, an ACIOL is a very good options. And a young patient, I will try to do a sulcus fixated IOL, either suture or like sutureless.
Srini?
Yeah, if in case of aphakics, I always prefer, if the capsule of course is not there, I go in for the sutured SF IOLs. I feel that further, if there are any vitreoretinal procedures being performed, the sutured IOLs really behave well. We did a study of 100 SF IOL sutured versus the posterior fixation of the iris claw lenses. And the iris claw lenses patient always complain of shaky vision. And sometimes when you put a gas or oil, there are chances that it will come up into the anterior chamber. So a good posterior, kind of mesh, which gives is the sutured, and of course, if not, then sutureless SF IOLs.
So generally, when you have many techniques of fixing something, that means you usually do not have a good technique of fixing it. Every year or every 2 years, they come with a new technology, the new technique of suturing or sticking the sclera. And these are usually not that easy, as is usually shown. And many times the lens is a little bit tilted, or the lens falls back, or you get exposure later on. And at the end of the day, as David pointed out, I think worst case scenario, just put an ACIOL in. I've never seen a patient losing vision because of an IOL. The lens is usually not the problem. It's usually the retina. So even if you have a complex surgery, you may want to just do a lensectomy, clean it up. Or if you do cataract surgery, just do the phaco and put a lens implant. But I don't think you want to put an ACIOL and complicate things, especially as you pointed out, if you put a tamponade agent, gas or oil, then comes to the anterior chamber. and then can complicate things. And later on can always be put a lens implant at a later time point. I think our time is up. I would like to thank the speakers for the great cases, for you all to still stay awake, and for Alcon for the sponsoring. Thank you.